Really cold, record-setting cold January night. Yes, but we're going to talk about innovative techniques in tonsillectomy. We will go over the history of tonsillectomy, indications, the physiologic and anatomic aspects of the tonsils, and then we'll get into sort of the techniques and the advantages and disadvantages of those. So let's get into it. It's an important topic. More than 500,000 tonsillectomies are performed in the United States in 1 year. And I just learned this today, so you won't see this on your handout there because I keep on putting new stuff in here. Tonsillectomies form 1/3 of the number of operations performed under general anesthesia in the United States. But I think Ann will confirm that they're not 1/3 of our operations at South Suburban, but it would be wonderful to have it that way, but not quite the case. Most tonsillectomies are performed on children. Though again, I think my experience, I think just the way the demographic works out is about 90% adults. So it's very strange, and it's a little bit more challenging to tell you the truth because kids are very nice to do, but it doesn't always happen that way. Of the tonsillectomies performed on children, 80% are for obstructive problems, and that's probably why you have this 500,000 number here, because tonsillectomy sort of went out of favor, but then as the issue of obstructive sleep apnea, and especially sleep-disordered breathing, comes into play, then it became much more relevant because there have been studies that dealt exactly with that. Previously, it was more for chronic infection, and that's what you see in adults. And I found some very interesting ancient history of tonsillectomy, and it's fascinating to see what these people were dealing with because it's exactly what we deal with today. These people were truly heroes or truly I don't know what, gung-ho about this, but how much do we remove? Subtotal would be, subcapsular would be a total tonsillectomy, intracapsular would be a partial tonsillectomy. How do you dissect them out? Bluntly or sharply? How to control the pain, though in the ancient days the control of pain was pretty much getting an assist to hold the patient down, so not much pain control there, but how to control bleeding, they had their own various concoctions. The only thing missing in the ancient history of tonsillectomy is the issue of cold versus hot dissection, which is a big thing in the modern era. The first mention of tonsillectomy refers to Hindu medicine about 1,000 years BC. And this really is not describing tonsillectomy, but it's describing treatment of a peritonsillar abscess. They talk about it being, large and full like a bladder. When troublesome, they are to be seized between the blades of a forceps, drawn forward with a semicircular knife, cut 1/3 of the swelled part. If all be removed, so much blood may be discharged that will destroy the individual. If too little is removed, then you're not going to solve the problem, and you might get fainting, etc., etc. So that was quite interesting, 1,000 years BC. Now the actual first tonsillectomy was recorded by a physician named Celsus in the 1st century AD. He would use finger dissection, and when that didn't work, he would use a hook and a knife. And all this is relevant. I was taught finger dissection, and this idea with a hook sort of tells you how you draw the tonsil out of the fossa. So we'll be revisiting all that. Galen, apparently, was the first writer to advocate the use of a snare for amputating the tonsil. This also brings me back because my initial technique taught by me at the University of Chicago was a combination of finger dissection and snare. So how interesting that this was being done in the first 200 years AD. Paulus Aegineta talked about don't take out the tonsils when they're acutely inflamed. Wait till they get small and constricted. So a lot of times you get these people that get admitted to the hospital, especially if they don't have any insurance. They say, well, can you take care of me? Can you do everything right here while I'm in the hospital? But it's obviously much more difficult to take out an inflamed tonsil than it is to wait until it's much more less inflamed. And they talk, those that are spongy and red have a broad base are apt to bleed. It was like, no kidding. So this was his technique. One assistant holds the hands of the patient, the other one presses down on the tongue with a wooden spatula, and you take a hook and perforate the tonsil, drag it outwards as much as we can without drawing its membranes. We'll talk about those. And then we cut it out by the root with a scalpel suited to that hand. There are 2 such instruments having opposite curvatures, so that's very advanced too. And I'm very strongly right-handed, but the only thing I do in my entire life that's left-handed is take out the left tonsil, and that's usually how you do it. And fortunately, these instruments are easy enough to use that you can do it that way. But how interesting that they had this. By the way, this is the article I took all this from by Ronald Alistair McNeil. So he really did a lot of research on this. Guillemot, a pupil of Ambrose Paré in the 1500s, pulled the tonsil out of its bed, then a noose of thread or wire was slipped around its base and tightened until the circulation was cut off. You can imagine how comfortable that would be. And I love this description that he follows with this. One writer was moved to talk about this. This procedure was liable to resolve itself into physical combat between the surgeon and his victim. I can see that. It reminds you of a few weight tracheotomies I've had to do. It's like, oh boy. And this gentleman, I didn't realize, but maybe Jim would have some interest in this. Philip Singh Physic, an American, the father of American surgery. He pioneered the use of the stomach pump, used autopsy as a means of learning, excelled in cataract surgery. How strange is that in the 1700s? Matter of fact, though, it's not that strange because I'm a classical music lover, and both Bach and Handel, Bach died in 1750, Handel in 1759. They both had cataract operations. Both had cataract operations by the same surgeon, even though one lived in London, the other one lived in Leipzig, and they both died blind. It didn't work. But anyway, so people were doing cataract surgery, and he was a pioneer there. But he also invented the guillotine or snare for performing tonsillectomy. I put down partial, but then the next quote sort of contradicts that. Evidently, when President Andrew Jackson consulted Physic about his lung hemorrhages, he was told, "Stop smoking." So this guy was ahead of his time. The guillotine for the tonsillectomy, it's easy to cut off the whole or any portion that may be necessary. The operation can be fulfilled in a moment of time. The pain is very little, and hemorrhage is so moderate that it does not require any alteration in 4 cases in which the doctor has recently performed it. I think this is very popular. People would just snare these things off or just guillotine them off. And this became, throughout the 1800s and probably into the 20th century, especially your family practitioners taking out the tonsils. And this is a tonsillectomy or guillotine. Obviously, you just draw the tonsil into there, pull it out, and if this blade is sharp, evidently it just cuts off a portion of it. If it's dull enough, you can sort of just extract the tonsil and then just take it off. Anyway, this is only, I think, funny for people that are interested in classical music, but there's a trend in classical music to perform the pieces on the original instruments, like what Bach and Handel would have used in the 1700s. Obviously, you don't want to perform an operation using original instruments, but I'm sure this patient is not too eager to have that done. Anyway, what do tonsils do? Well, they're part of the immune system, and they do synthesize antibodies, immunoglobulins, especially IgA for the mucus, saliva, and tears. They also produce lymphocytes. And if you've probably heard about Waldeyer's ring, you have the adenoids behind the nose and the nasopharynx, you have the palatine tonsil. We're really talking about the quote-unquote palatine tonsils, and there's a lingual tonsil, so you have like a ring, and that does cause contact with pathogens, and that's part of our immunity. Though no one has ever shown, and many people have looked at this, does performing a tonsillectomy reduce your immunity to infections? Absolutely not. We have plenty of other tissue like we just talked about. The rest of the Waldeyer's ring does the same thing. Though I think there's a lot of folk medicine that the tonsils are like speed bumps for your infection, so if you take them out, the infection will just rush right into your lungs or something like that, but it's not really true. So why do we take out the tonsils? Well, infectious indications. And this has now been codified in the American Academy of Otolaryngology Head and Neck Surgery. It used to be sort of an informal type of indication, but this is what we're supposed to follow for pediatrics. But again, remember, pediatrics usually does not involve infection. It's more likely to be obstructive, sleep disorder breathing. But 3 infections per year for 3 years running, 5 per year for 2 years, or 7 in 1 year. This is sort of strep. So this is a lot to ask. The informal thing that I tend to follow is 2 weeks of work or school absence in 1 year. If you're having such bad tonsillitis that you're missing a lot of school and work, I think that really says something. Or sometimes I'll just say, if the tonsils are regularly ruining your life, you probably would be better off taking them out. Now, modifying factors, all these other ones, I really have not dealt with, antibiotic intolerance or resistance and all these other things, but definitely peritonsillar abscess. It used to be 1 peritonsillar abscess and you're out, meaning okay, we'll wait for that to settle down, we're going to take out your tonsils. Now, if that's just an isolated peritonsillar abscess, we really don't do that. However, the second strike and you're out. So, I mean, a second peritonsillar abscess we would strongly recommend. Obviously, this is getting to be a pattern, and you should probably take these out. But again, it's not an absolute indication. And just like we talked before, this is, I think, a very, very important issue. Children with sleep disordered breathing, and we call it sleep disordered breathing if you don't have a sleep study. It's sleep apnea if you actually have it proven by a sleep study. But I call it the mammogram. If the mother tells me, listen, my child has restless sleep, obstructions during sleep, and then we look at them and see these huge tonsils, you know, I don't really require a sleep study. And I think it's extremely rewarding because usually you do have a growth spurt the year after you take the tonsils out, but things like enuresis, very upsetting, behavioral problems. As a matter of fact, there's a study, which I didn't put up here, but that's shown that children that have ADD and tonsillar hypertrophy with the sleep disordered breathing and have the tonsillectomy will oftentimes reverse the diagnosis of ADD. So I think it's a huge percentage, up to like 50% that went into this with ADD. A year later, they don't have the diagnosis. So I think it's really gratifying because basically, it's not like, I mean, Dr. Judd would be talking about a very complicated anatomy, very delicate, you know, very risky and all this other stuff. And this is a very basic operation, but it has a lot of great benefits. Technique, some like it hot. Well, I decided to, though I'm not the witty person that actually brought up this connection, but here's some like it hot, Marilyn Monroe, Jack Lemmon, and Tony Curtis, and all sort of things. But there actually was an academic study that was entitled Some Like It Hot, Tonsillectomy, Some Like It Hot. This is from National Library of Medicine, and this was 1984, so this was just coming on the scene where they said we should look into this because people are more and more using cautery for their tonsillectomies rather than cold steel. And the basic take-home from this was that tonsillectomy on electrocoagulation was found to reduce operative time and blood loss, but to increase post-operative pain and prolonged healing. But this became more and more popular for obvious reasons, because you have great hemostasis during surgery, and it's an extremely quick technique, astonishingly quick. Just cut out the tonsil. I mean, it's not probably as quick as a tonsillectomy, but this would be what I would call tonsillar nirvana. Get the speed and hemostasis of a cautery tonsillectomy with the tissue-sparing, decreased pain, and decreased edema of a cold steel tonsillectomy. And here's my tonsillectomy odyssey. I was taught at University of Chicago. These are sort of my otolaryngology years, right? I did 2 years before that in general surgery, but we used a sickle knife to cut the mucosa, scissors, like a Metzenbaum scissors, to find the plane between the tonsil and the muscle bed. At that point, you take your finger, dissect the tonsil away from the muscle bed. But you can't really either get your finger down to the inferior polar. It's just too much of a adherence there. So then you take a snare and snare it off. Of course, it bleeds like crazy at that moment, so you put a big pack in there. Then you grab your suction cautery and you start cauterizing. And to my mind, this is the worst of all possible worlds. You got a lot of bleeding, you have a lot of cautery, tissue damage, and so, and the worst of all, this actually was the worst of all thing, was that they tended to ooze in the PACU. The last thing on earth you want to do is have the nurses talking about you and your tonsillectomies compared to those cautery tonsillectomies. So I asked someone, well, how are you taking them out? And he said, I use the cautery. This is truly a see one, do one. I mean, it's really quite simple. The cautery, though, it does have a lot of heat. It doesn't spread that bad, but it's certainly hot. Great hemorrhage control, fast tissue preservation, but a lot of edema, pain, delayed healing. KTP laser, I think, was sort of a joke because you would cut, it would bleed, you would use the cautery, you would cut some more, you'd have a laser technician, you'd have to set it up, the anesthesiologist would be worried about the tube getting it on fire, but it had great cachet because you would say, wow, I'm taking out the tonsil with a laser. And some people would play on that, but I just didn't think it was practical. Harmonic scalpel, I had one case that I can remember. I think I may have done 2 or 3, but this lady, it took like 40 minutes per side. Her uvula swelled. She had a post-op bleed, so it was terrible. I had to amputate the uvula in the office. I just never did it again. And the technique was different too, because you heard about all those things about hooks and tenaculums and things like that, but this you're not supposed to pull on the tonsil. You're supposed to just slice it. It was really not intuitive. From 2000 to 2010, I used this coblation, which is the term for cold ablation. It uses radio frequency, and it was much colder. So we're getting close to nirvana, but really not exactly there. It also had a limited bipolar cautery on the other side because the hemostasis was good, but not that good. And so you would just do that. And this was all irrigated. So you'd have a saline irrigation to set this off. Good hemostasis, pretty quick. You had to change every team to set up the irrigation and make sure they had the foot pedal right and everything like that. It was a bit of a hassle, but I was happy with it overall. But I don't think the pain control was that much better. Maybe a little bit, but not much better than the cautery tonsillectomy. And so, remember, 1984 was something like a hot paper where they say this new technique of cautery. And then by 20 years later, they did a survey of about 400 ENT doctors, otolaryngologists, and by then, monopolar cautery 224, bipolar 15, blunt dissection 4, sharp dissection 73, harmonic scalpels 12, laser 7, suction cautery. Actually, one of my co-residents, I asked him, 4 or 5 years out of residency, how are you taking out the tonsils? He uses a suction cautery. I didn't really know you could cut that well with a suction cautery, but I don't know you can. Ultrasonic, which I think is the same as harmonic scalpel. Coblation, so when I was doing it in 2000, the coblation, only about maybe 1% of doctors were doing it at that time. But then, here we are 7 years later, another study. The coblator was the most common single instrument used for tonsillectomy, followed by monopolar cautery. And evidently, monopolar cautery in combination was more common at 33.5% than coblation. But you can see that people really did like it hot. But again, it was very efficient, very efficient. I thought I'd talk about a little bit of anatomy here very quickly. The tonsil is in a fossa, so there's a posterior pillar or a posterior fold. That's the palatopharyngeus muscle. And then the anterior is a palatoglossal muscle. So they go two different directions. One goes into the throat, one goes into the tongue. And there's the tonsil just within there. The tonsil does have a blood supply, and boy, do we get some bad publicity from California. But there are 5 arteries. I used to get pimped on this at University of Chicago, so I memorized this at one time. But the facial artery supplies some, lingual artery supplies a lot of blood. Do not hit the internal carotid artery, but it's really well protected. I mean, if you see a big pulsation, you probably would want to, be extra careful. But it's really not. It doesn't really come into play unless you really lost your bearings. You can't see this. So from 2010 to the present, I started using this tissue welding technique. I guess it must be either my striving for improvement or just my poor personal stick-to-itiveness, because this technician, this equipment tech, you should say, try this. I said, no, I like what I'm doing. No, I like what I'm doing. Finally, he sort of wore me down. I said, okay, I'll try it. And it was very tedious to learn the technique. But the technique is the tissue is heated with a heating element. It's not electrocautery, and the heat dispersion is not much beyond body temperature. In my hands, it's a much longer dissection. That's because I'm preserving a lot of tissue, but there's good hemostasis. I actually use a bipolar cautery for any incompletely cauterized vessels with this technique, because the blunt tips of this really don't catch the vessels very well, so I use a bipolar. And it's interesting, too, because you would think a bipolar cautery at 15 watts is like super gentle. I remember when I was in my fellowship, I actually was bipolaring little vessels on the surface of the cerebellum. I don't do that type of work at all. I really abandon that type of thing. But bipolar cautery, it's a sensitive technique, but when you look at the bipolar cautery in the bed of this tissue welding technique, it looks terrible. It looks like you're burning the tissue. It looks grotesquely burning. So it's an interesting indication of how tissue sparing this is. And I think it does have significantly better pain control. I remember my nurses, remember these are all adults practically that I do, and they're just saying, wow, we're not getting the phone calls. We have to call them up to see how are you doing. They're just doing fine. And here's a video of it just to sort of show you. Good. I think it's happening. So this guy picked the world's easiest tonsillectomy to do this. I mean, Jim could take his clamp, just go across here and cut with his bovie and say, okay, I'm done. It's been 2 seconds. But this guy, he's no idiot. He used a very, very simple tonsillectomy. But here you see the heating element. It's not really, the sound isn't coming through, huh?
Yeah, it probably turned itself off.
But in any event, he's just talking about how he can use if you heat it quickly, it cuts the tissue. If you heat it slowly, it seals the blood vessels. So there's two petals on the ground there. And that's how this works.
So, Chuck, is this like a bipolar technique, though?
It's like I would call it a bipolar technique because I just pinch and cut and pinch and cut and pinch and cut. That's really.
But it's called tissue welding.
It's called tissue welding because there's no electric current that goes through it. And actually, I think this is also interesting for things like thyroid or something like that. If you want to monitor the blood vessels, it's always been a freaky thing because the one moment that you want to see whether the nerve is being irritated is the one moment that the electricity is going to the body and the electromonitor, the EMG, cannot pick it up. So this is actually, I've done a couple of projects with this. It's very nice because the monitor, your monitor is totally intact because it's just heat. There's no current going to the patient.
And what's the temp, Chuck?
Well, the temp at the tips is probably just below just below 100 degrees centigrade, but it doesn't disperse hardly at all. And I do another thing. You'll see that I actually irrigate with saline during this, so I have even less heat dispersion. But you'll see the one thing about this. This was almost like a useless demonstration, except for when he's done here. The thing that sort of inspired me was, you see, I mean, this was like a trivial tonsillectomy, but I don't know if I can pause this, but there's almost like no raw area there. He preserved the whole anterior pillar. He preserved the whole posterior pillar. I wish I could pause this, but. And I said to myself, well, if I had this result on a true tonsil, which is going way into the fossa, because usually you don't get this, you get it way into this area there. And the old technique with the cautery was, well, I cut away the anterior pillar to get a perfect exposure at that plane, and then I would dissect down. But I just said to myself, well, if I keep on cutting and rolling and cutting and rolling and cutting and rolling, I can preserve the anterior pillar. So anyway, that was my lesson from that video, was preserve tissue. So that works. So that's my Beethoven inspiration here. So I just do not remove the anterior pillar for exposure. And it's tedious, and it's slow, and it's annoying, but I think the patients really do a lot better. So anyway, here's
so the heat is provided for what?
I don't know how it's provided. It just ends up like almost like it's so trivial. It's just a heating element. It's just a heating element. It's connected to just a little box. So in terms of setup, it's like plug it in, put the foot pedal down, set the level at what I want, and you're done. That's the total setup.
It's a cord.
It's a cord. And of course, they're selling you this disposable handpiece. I sort of doubt we can reuse these.
Yeah.
So that's where they make their money. I mean, the foot pedal is for free, but
it's not a lot of electric current then.
It's not going through the patient. I don't know what heats the area, but whatever it is, it's not electricity going through the patient.
But it creates a plume of smoke.
A little bit.
Well,
a little bit, but if you irrigate, you don't even see that.
I mean, but I'm just saying, those. Where do you create? At what temperature do you actually explode the tissue to create a plume?
I think it's about 100 degrees Celsius. I don't think it's much more than that. So I'll try to pin that down for you. But this is published in 2011, and it compares like all the major ways of taking out the tonsil. Am I getting? Oh my God. Yeah. So I practiced saying this: vessel sealing systems. That would be the tissue welding thing, harmonic scalpel, radio frequency ablation, and then cold steel or electrocautery. I think the take-home message is that all these other four techniques really were pretty much the same in terms of pain, healing. I don't know if I really agree with that. I think that the cautery's probably got to be worse for the healing. But in any event, they couldn't show with this. This is a meta-analysis that anything was improved if you took these other techniques. But the synthesis of the limited shows that there's a significant benefit for these vessel sealing systems.
All right. Thank you.
This is one of the people that were first using the vessel sealing system. So this came out in 2006. And so, again, it showed mean postoperative pain score and mean time for return to normal diet were significantly lower in the tissue welding tonsillectomy group. And this was compared to bipolar, again, a relatively gentle technique. So comparing, not cautery to this, but bipolar cautery. 2008. This compared, maybe, Jim, you know what this is. I'm not sure. This, I think, is another vessel sealing system, but...
Oh, ligature?
Yeah.
Yeah.
I don't know if that's a heat one or whatever, but it was shown, whoops, I keep on hitting the... It was shown to be tissue welding tonsillectomy is shown to be significantly better than this in terms of the postoperative pain score, because then it's all about the pain. So adjunctive intraoperative treatments, steroids, we all use steroids. They help with the issue of swelling, nausea, and they get the patient off to a good start. But I was always worried that if I gave a lot of steroids, and there were some studies that gave a 0.5 milligram per kilogram of dexamethasone up to 20 milligrams, which is a big dose. You multiply that by 6, that's your prednisone dose. So that's a big dose. But I was always worried about delayed healing and maybe delayed bleeding with that. So now I use much, much less steroids. For a few patients, I've done this where I try to anesthetize the trachea, because I had I had 2 bleeds in about 60 patients, and one of them had such tremendous valsalving and bucking for like minutes and minutes before they extubated him. I thought, this is not good. You talk about like all these other things, don't lift heavy objects, and here these persons going, So I sometimes do this. I do not inject locally. I could go into that, but I think that's a completely bad idea. Antibiotics, I still give this, though my academy, otolaryngology head and neck surgery, says don't do it in the most recent criteria or guidelines, but I was taught to do it. It seems to be helpful, but they don't think that it's the benefits of less pain, less bacteria, which have been shown to be the case, are offset by the increased resistance or antibiotic side effects. Irrigation, I've been doing that. That sort of eliminates the plume of smoke. So this person in 2013 published a study that irrigation seemed to help, and since I became like Mr. Pain decreased tonsillectomy, I thought I would do everything I could to decrease it. So this seemed to be helpful comparing one side to another that both had a tissue welding tonsillectomy. And this, I think, is a huge issue. We have several pediatricians here and family medicine doctors, is that you want to avoid narcotics in young children. The FDA, I guess it's not that recently, but they issued an alert warning specifically about tonsillectomy. The risk of fatality when codeine is used after tonsillectomy. I can tell you that for about 20 years I gave Tylenol with codeine. That's what we gave. Here's liquid Tylenol with codeine. They also had that other one that was alcohol-free, but it was always Tylenol with codeine. But with this type of technique, I don't have to use that, and I don't use it in children. But there were, and of course we're not talking about this person in California, but there were 3 deaths and 1 non-fatal life-threatening case of respiratory depression from this. And so now it might have been a personal quirk of mine to try to have the patients not have a painful tonsillectomy, but now I think it's even more important.
And what analgesic you want to use?
I use regular Tylenol, liquid Tylenol, and liquid Motrin. And if they have a problem, I might give Pediapred, but they get by with this. I did a 2.5-year-old, which I was a little bit queasy about. Matter of fact, this was something that we brought up on the surgery executive committee, is that the ASC, the Ambulatory Surgery Center, was reluctant to hold this person in place there for 4 hours. I said, I want to have at least this person observed for 4 hours before I send a 2.5-year-old home. But he was swallowing like a champ, and so I said, well, fine, we'll do it. But yeah, antibiotics, steroids don't taste very good for children, but and that's really like a save. If someone calls me up and says, I'm really having problems, and I expect, of course, now they have expectations that they're going to just do great. Sometimes I'll add a little bit of this in since I didn't give too much in the surgery. So again, this is the same thing. Whoops. Okay. Save the tissue. Okay, you heard that. So,
excuse me, do you apply the same technique for adenoidectomy also, for adenoids?
The adenoids, I just use a sharp curette and the suction cautery, because the adenoid area is very resistant to pain, resistant to bleeding. That's why when you have and Dr. Gindi knows this, when you have nasopharyngeal carcinoma, usually the first thing you see is like a neck met. You don't have, I mean, you may get skull-based pain, but that would be advanced. Usually you don't have anything happening in there, so it's a relatively dead area there. But these are those people that showed up in my office over the last couple of weeks. I said, well, I got to have some pictures of these are not my tonsillectomies, but you can sort of see how sometimes people take off the posterior pillar here. There's not much anterior pillar here, so just clean it out, you know, and whatever you get in your snare or whatever you cut away, and as long as you get the tonsil out, I mean, the patients just have to lump it. Here's her other side. Here's another patient. These are, like I said, literally patients that came into my office like last week. And you can see there's just not much there. Her palate scarred right into her faucet. Now, there's such a thing as uveal palate. I had a patient today, so I put that picture on here too. So I was thinking to myself, it's not like it's terrible if you cut off the anterior pillar. It's like you're giving them a uveal palatoplasty and opening up their airway for no extra cost. But when it comes to pain, though, there is a cost. When it comes to pain, if they expect low pain tonsillectomy. This is my wife, Marie. She had her tonsils out at age 5. Now with your video, you do a selfie of your throat, and she had a lot of tissue. She had a lot of tissue removed. Here, like when she elevates her palate, you can see a little bit of anterior pillar, but a lot of it's gone.
What does it look like when she's elevated?
Well, that's about right. She's a soprano, so she can really elevate her palate. So but I wonder too about about preserving tissue. So here's a patient showing up at my office today. That's what a uveal palatoplasty looks like. And so here, the whole goal is to like remove the anterior pillar and like sew it to the posterior pillar. I don't know if you've done these, Jay, but I always thought it was like sewing 2 railroad tracks that are going in different directions together. They don't stay together. No. They sort of just scour up. The uvula goes with this. This is like opening up. This is like for a patient that had like bad sleep apnea and snoring. And so anyway, but this is a patient of mine, a very sensitive patient that came because now it's on the internet. There's a YouTube videos of people getting these tonsillectomies done. So they call the company up and says, who does this tonsillectomy? So this guy came from about 15 minutes away from a different suburb, and he showed me how bad his tonsils were they inflamed. Obviously, I didn't take them out when they looked like this. But you can sort of see he's got a big anterior pillar here. He's got a relatively small anterior pillar here. So not always symmetric, but those are definitely inflamed tonsils. He had multiple of these episodes. And here's his post-op picture that he sent to me. There's the anterior pillar. You don't see the posterior pillar as well, but I think that's because the anterior pillar is so prominent. But if you look closely, you can see there's the posterior pillar here. There's the anterior pillar here. It's all intact. So these are my results. Much better pain control, fewer phone calls. Even I would tell the staff, because they say, gee, this is taking a long time. For every minute extra I spend in the OR, I'm probably saving myself 5 minutes on the phone to explain to these patients why their pain is. Much less edema, fast healing, earlier return to work. I had one patient, because I remember this distinctly, she had the operation on Friday, and then she went back to work as a restaurant hostess on Thursday, because that was Thanksgiving Day. She wanted to work on Thanksgiving Day, and I was thinking, oh, this may be questionable, a 24-year-old, but she went back to work. I had one guy that went back to work 3 days after his tonsillectomy. He was like a warehouse supervisor, so I don't know if he was just like downing the Tylenol codeine or what was happening. Now, I've had 2 bleeds, one on post-op day 2. Post-op day 2 is very strange. It's usually immediate bleeding or like post-op day 6 when the eschar sort of comes off prematurely. And that's one thing I love about this, because when patients are drinking, that eschar stays thin, it stays slick, and I think there's going to be less post-op bleeding. That's what some of the other studies show, but it's hard. I really have to do more formal numbers. And I have one tonsillar cyst infection where a girl, I took her tonsils out, and she had, like a year later, she had a sort of small abscess and a cyst that was there. And it's well known that you can get mucus retention cysts, but I hadn't really seen them. So I don't know. So anyway, I don't know if this counts as, no one's ever paid me anything from Microline. I got no money from them, but they do have a website, and people do call them up to say who's doing this procedure, and they have the website in alphabetical order. There's Colorado, there's South Carolina. You say, well, where's Illinois? So I am getting some people coming from far away, and it's sort of gratifying, but I'd love to do more. I don't know if there's any other way maybe to get people knowledgeable about this technique, but I think that it's really going to be the coming trend. Just like coblation, it took them from 2004 to 2011 to become the most popular way of taking out the tonsils. I think this is going to happen. But right now, I've got a monopoly in northern Illinois. I guess there's someone in Jackson, Illinois, and someone in Springfield, Illinois that's not on the website, but so far it's just the three of us. And the patients tell me this. I mean, they call Microline and say this. So anyway, thank you. Yeah, I was hoping. Thanks, turn back. This is Marilyn Monroe singing Heat Wave.